Okay, now let's talk about alarms. The vent is alarming, and so it's a high pressure alarm. And so you go in there and it's high pressure, and you ask for a plateau, and the plateau is, let's say, 45. What's our goal plateau? Less than 35, ideally less than 30. So what are some causes of a high peak and a high plateau pressure that are inside the lungs? So what problems might we have inside the lungs that causes a high pressure, both total pressure and resting pressure in the lungs? What's that? Poor compliance, so restrictive lung disease. Okay, what else? Auto PEEP, yep. Breath stacking. What else? Pneumothorax. Yep, pneumothorax will do that. So ARDS, pulmonary edema, pulmonary fibrosis, pneumonia, basically anything that's making it difficult to deliver the tidal volume is going to increase the pressure in the alveoli and the big pipes, okay? What about outside of the lungs? What are some extrathoracic problems that can cause high pressure, both peak and plateau? Obesity, yeah, potentially. What's that? Burns, right? So basically something where you need an escharotomy because they're constricted. Ascites, abdominal binder. Acute coronary is in there, and I'm not exactly sure why that's going to give you a high pressure. Obesity and body position. We talked about optimizing the body position. Okay, so now you got this alarm. Here's your differential diagnosis, these two columns here. So how are we going to fix this? So if it's ARDS, Jim, what are you going to do? What change are you going to make to the ventilator? So we need to lower the pressure. So going on the rate probably isn't going to help us because it's going to basically maybe even stack or give us a higher minute ventilation. So what we want to do, what's that? Decrease the volume and increase the PEEP, right. Increase the PEEP. So increase the PEEP and FiO2. Okay, what about, Chris, for pulmonary edema?
More pressure.
So increase the PEEP?
Yeah.
Okay, seem to have a trend going here. LA, what about pneumonia?
Same thing.
Right. Okay. Jonathan, what about atelectasis? What about atelectasis? Yeah, PEEP, FiO2. So with ARDS, remember it's not heterogeneous. There's patches of lung that are basically not functioning, but there's patches of lungs that are normal. And so that high PEEP is essentially ignoring the bad lung and working on the good lung. Same with pulmonary edema, same with pneumonia. We're essentially trying to recruit as much of the good lung as we can, knowing that there's a patchwork of bad lung in there. And so it's kind of the philosophy is the same whether it's ARDS, pulmonary edema, or pneumonia. Okay, what about auto PEEP, Mike? Right, so the first thing you want to do is you disconnect the circuit. And the next thing, and this is a potentially life-saving move, literally take the patient's chest like a bellows and squeeze that dead space out of them. And it's pretty remarkable, but they're going to be hypotensive, peri-arrest, and disconnect the vent, and basically like a accordion, squeeze them out, and then hand bag them with a PEEP valve and really feel that expiratory time and prevent the stacking. Then once you figure that out, get them back on the vent. But that's a life-saving move for auto PEEP. Pulmonary fibrosis. So you can't go up on the PEEP when you have pulmonary fibrosis. So what are you going to do? FiO2, and you're going to do a low volume, high frequency strategy. So basically you're going to have a lower tidal volume and a lower PEEP, and you're going to go way up on your rate, almost like what do they call it with infants when they do that ventilator setting, the high frequency oscillation. But we're going to do kind of a version of this for adults. And pneumothorax, obviously we're going to fix that with a chest tube. There it comes.
Jesse,
Yeah.
With the auto PEEP, with changing the IDE ratio?
Yes. Absolutely. So once you get them back on the vent, you want to pay attention to that IDE ratio. And one thing you want to think about, and this is where RTs are good at protocols. This set of vent settings works for most people, but somebody with COPD or status asthmaticus, you want to be very aware of that IDE ratio, and you want to know about is it on a ramp or a square form in terms of delivery of the flow. You want kind of a gradual flow rather than that sharp delivery of flow. So yeah, those are important things to consider.
This may be a stupid question, but what if somebody's in status asthmaticus and they need the IDE ratio, but they also need that respiratory rate. And you can't do all of it in the minute.
Yeah, so the question is, you have a status asthmatic patient, they're not tolerating the volume, but they need the volume to oxygenate. What do you do? And in that case, you have a higher peak and plateau, and you just manage them through with, hoping that the nebs and steroids are going to kick in to decrease your airway pressure, maybe nitrous oxide to help, but they're, because it's oxygenation and a ventilation issue for them. So, but to answer your question, you just have to tolerate a higher peak and plateau, and you're going to basically drive, and you may have to have sequential times where you disconnect them, you do the bellows, fill them back up, disconnect them, and basically until the nebs and steroids can kick in.